Hi, good afternoon, everyone. Thank you for joining us today. I have a few housekeeping rules to note before we get started. This event is being recorded and the recording will be posted online afterwards. And then if you would like to access, we have speaker biographies and slides that are available online. And to hide captions or adjust settings, feel free to click the hide or show captions button. All participants are muted, but you can type your questions in the comments Q&A box at any time. And then please take 1 to 2 minutes to complete the survey at the end of the event. And then lastly, engage with us using the hashtag #liveaturban. So you all should be in the right place. We're here today to talk through understanding training and workforce pathways to develop and retain Black maternal health clinicians in California. And my name is Iona Harrison. I'm a senior research associate here at Urban Institute. And my work focuses largely on health equity with a significant portfolio on maternal and reproductive health. I'm a principal investigator for this work, and I'm very excited to share it with you today. So let's get started. Let's jump in. So a little bit of background and purpose of this work, let's get started there. So this work is presented here today was supported by a grant from the California Healthcare Foundation. And the California Healthcare Foundation is an independent nonprofit philanthropy based in Oakland. And they began investing in birth equity, specifically Black birth equity in 2018. And CHCF aims to improve maternity care and maternal outcomes by, with, and for Black mothers and bringing people and birthing people, in California. So CHCS portfolio currently focuses on 4 different areas, and those aims are under data monitoring and transparency, as well as measures, delivery, system interventions, workforce, which we'll talk about today, and then as well as community voices and engagement. So today we're focusing on workforce, and there's recent evidence that shows that by increasing the diversity of health care workforce, you can reflects the population served, then that does improve outcomes. And I can contextualize that a little bit more. So if we're speaking about the public health crisis in the US maternal mortality rates surpass other industrial countries threefolds. And then the Black maternal health crisis, Black birthing people in the US are 3 to 4 more times likely to die from pregnancy-related causes than their white counterparts. But there is evidence that supports that race concordance. When you have a provider and a patient that share the same race and specific birth teams, it can improve your outcomes. Now, I do want to take a second as we're talking about increasing and supporting Black maternal health workforce. We must situate that in the context of acknowledging the very relevant history of these professions. So the first one is the American gynecology being built on crude experimental procedures performed on enslaved Black women. And then there's Black midwives or granny midwives who in the colonial era and also after in the emancipation were important members of their community and attending most births for Black and poor white families in the South. Yet by the 1900s began the systemic erasure of midwifery by early obstetricians. So eventually midwifery was essentially abolished, and not until the 60s or the 70s, we've seen the reversal and its uptick today. But I do wanna say there are still limiting guidelines and variations across states. So all of that must be considered in this work as we continue this discussion around increasing and retaining our Black maternal health workforce. So let's jump into the research. A quick overview, the research included in-depth interviews with Black maternal health clinicians. And for this work, when we say maternal health clinicians, we're speaking of obstetricians, labor and delivery nurses, often referred to as L&D nurses, and then midwives. And there are so many types of midwives. We spoke with certified nurse midwives, certified midwives, certified professional midwives, licensed midwives. And then we also were sure to speak with other stakeholders, including educators and training program leadership who are, equipping our next generation of maternal health clinicians. And our goal here was really to better understand what are the factors that either generate or minimize these barriers to entering or staying in the profession, and then that impact of licensure, reimbursement, and scope of practice guidelines, because here that really does matter and impacts where folks practice, who they may serve. And we'll dig a little bit more into that. So our findings fell into 4 themes, and those are difficulties in the career journey, so charting a pathway, barriers in education, financial barriers, and then profession-specific hurdles. So please forgive me for the light touch or the quick pass I may do over these. I really do encourage you all to read the report and our related blogs for a comprehensive experience that were shared, but I want to make sure that I give a quick overview. So I'm going to jump a little bit into each one. So with the difficulties in a career pathway, a lack of career pathway information, particularly for first generation health professionals, was often cited as an enormous hurdle. So interviewees shared that as students, they were not able to easily chart a path for their desired goal. And then interviewees also noted instances where professors and other colleagues actively tried to redirect them from the profession. So we have stories, if you read in the report, we have stories of like professors withholding information, and you finding that same information out later from another student, or being blatantly told that this may not be the profession for you, or you may not meet certain goals. These areas are hard, so maybe you want to think about going this way. So while trying to figure out a path, also being deterred from that path as well. And we did see that mentorship and community among Black providers were a protective factor. So while not everybody got the mentorship that was supportive, those that did receive it noted this as being like the reason that they were able to succeed. We also know that in the sense of community, interviewees detail how like Black students in their cohort or their program would seek each other out and make sure that they, were doing knowledge sharing and other support networking to make sure that they were able to get through and be successful at the end of this. And then quickly highlighting some of those barriers in education. So noting blatant discrimination, the study and practice of maternal health care is already demanding, but these pervasive racism and microaggressions and implicit bias really make it that more difficult for Black professionals. Interviewees describe many instances of active discrimination, and then instances of experiencing push out. So being having these experiences where they felt like folks were intentionally being mean to deter them from continuing their practice. Another theme around education is that fear of retaliation if discrimination or inequitable patient treatment was called out. And this fear was based on previous reactions from leadership. So imagine that having these experiences and having that fear during residency, for example, where that completion is a requirement to obtaining your license. And then financial barriers. So the cost of education has been on the rise, and maternal health clinicians are not exempt from that. While all students pursuing advanced degrees in health professions have this sticker shock, Black students are particularly affected because they tend to have fewer family and intergenerational resources. So the financial barriers were beyond tuition. So if you think about the paying for high quality courses to prepare for professional exams, paying for those exams, and then also childcare and housing fees, really something that people can't go without, but having to take on preceptorships or opportunities that were unpaid, but necessary for completing their training. And also we have quite a few folks talk about the healthcare facilities that they wanted to go into where they could primarily work with their communities that look like them, but these facilities who are primarily serving people of color often didn't have adequate resources to pay competitive salaries. So that right there was just another deterrent for folks to either go into the field or who they were providing care for. Now, I did want to highlight profession-specific hurdles. Now, we understand that not one approach will fit nicely for every profession, but to show up for each, we really wanted to highlight a few particularly unique factors for each. And this isn't exhaustive, but just a quick touch. For OBs, this long road from medical school to practicing included many opportunities for attrition or push out. So these sore points along that journey are opportunities to jump in and intervene and support this group. With midwifery, there was expressed desire for diverse learning experiences and preceptors. And preceptors are the time that you spend shadowing, for example, and working in the field, but these are unpaid typically. But there aren't any HBCU midwifery programs, so folks who wanted that experience couldn't get that. And then it does take time. So that preceptor match and time commitment without pay was a commonly cited barrier. Folks took years to find someone who was willing to work with them and felt like a good fit, but then also to be able to show up for the amount of hours that was expected. We also know that there was a desire from many of the interviewees to work in spaces where they would be, for example, working out of hospital, so maybe a birth center, but then later on finding these blockades where scope of practice or physician supervision requirements made it that they weren't able to do that. Now, we do know in California recently enacted the Senate Bill 1237, which removed the requirement that certified nurse midwives be supervised by physicians. So there is some progress there, but again, thinking about how these findings speak to the larger field, we know that every state has different requirements. So just something to look out for. Then with L&D nurses, this one, each labor and delivery nurse we spoke with charted a different path to the profession, and most noted luck, relationships, and like being in the right time or right place. And really that being the key to their entry into that profession after obtaining their RN license. But at the same time, while there were undefined points of entry, there were cliques and politics that could block entrance. So this was a profession that not only was missing a clear path, but also had invisible roadblocks. So clearly something that needs to be addressed in order to increase this workforce. And a bit about our strategies. So we, in our report, have quite a few strategies that we highlight that could potentially increase and support Black maternal health clinicians. And if you see in the corner, we have highlighted the 4 finding themes that really are our strategies speak to these. We have quite a long list. I, again, encourage you to go read the report. Each one has a sub approach that is really working to point to actionable strategies to speak for each. So those include providing financial support and reimbursement services, increasing opportunities for mentorship, removing barriers to midwifery practice, addressing staff diversity in hospitals, and then working with Black students at the primary education levels. So jumping into those, providing financial support and reimbursement services. So a common theme throughout all the interviews was this importance of how much debt was potentially being taken on, and then the fear and anxiety of that debt thereafter. So interviewees had these support systems there. They felt like, excuse me. Sorry, my slides look different than I think what was on the screen. So sorry, provide financial support and reimbursement services. So what that really is we're seeing that people are, again, taking on large amounts of debt, and that perceived amount of debt may stop folks from entering here, or have that, again, there we go. And then also have that fear of having to repay those loans afterwards. So we offer up a few different ones, which are state and federal subsidies for midwifery education, especially that trainee stipend and the stipend for the clinical training sites. So I keep talking about this preceptor time for midwives. So in residency for OBs, there is funding that is provided, and not the most funding, but funding that is provided to the student, the residents, and the accepting institution. But in midwifery, that's not happening, which could be adding to the difficulty of finding and landing a preceptor. So folks are having to find people, and then we know that with fewer Black clinicians who are in the field, those may be the people who are really getting tapped by those who are wanting to work with certain populations. So they're overburdened, getting asked by many folks, but may not themselves have the resources to take that time and dedication that's needed to really train someone. So providing a stipend to each individual could assist with finding a preceptor, as well as getting through those amount of hours that you're expected to do. Our next one is develop training and support programs for Black maternal health clinicians. So for this one, we have quite a few, and again, I'm going to keep saying, please read the report because we do have some more nuanced writings about this, but supporting these mentoring programs and then potentially convening Black maternal health clinicians. We know that mentorship was defined as the key success for many of our clinician interviewees. And finding someone who is a good fit can be hard. You may not find someone that's in your state, you may not find someone that's in your city, but these convenings nationwide could bring folks together and be tacked on with some type of support programs or financial programs that are giving time for people to get the mentorship that they may not be getting at their institutions, at their training institutions. Also, creating accelerated nurse residency programs specifically for Black nurses. I talked a lot about this focus of L&D and not having a clear path. That is one way to really draw a path for increasing Black nurses in this field, but also those who are interested. It could be that those who are interested may not ever have been exposed or don't know the entry point, or those who have the information doesn't mean that they're willing to go in here. So making sure that there are defined programs that people can call and ask and talk to someone and say, hey, I want to know a little bit more about this. And then also going through the program where they're coming out with a specialty area and then able to enter labor and delivery soon after. Also, removing these barriers to midwifery practice. Now, this is California specific, but a lot of these are, again, thinking about that context where state matters. So if you increase access to out-of-hospital deliveries by supporting birth centers, we spoke with a few folks who had quite a few blockades with starting a birth center or even keeping their birth center open. So partnering with those folks who want a birth center, we know that from the listening to Black mothers, the California survey, listen to Black Californias and mothers, there was something that came up, and off the top of mind, sorry, I don't have the number, but there was an increase in desire for their next birth to be in with a midwife or out of hospital. So with this interest in from the patients and not having the population ready to support these births, that is a clear gap. And we need to increase those out of hospital delivery supports to ensure that we have we can meet the need of the patients. Then addressing maternal health workforce diversity in hospital settings. Quite a few of our interviewees spoke about just the climate that is in the hospital setting. So as most births are happening in hospitals, this is somewhere where we want to make sure that we're addressing. So providing professional development funds to help drive diversity at all levels, training hospital staffs on more inclusive work and environment, and even using data to really check on these different metrics to make sure that staff are potentially looking like the patients that the hospital has, and all these various things that are really getting at to this climate beyond just increasing, like for example, we have the L&D new graduate residency program, but how are we ensuring that not only are we increasing this population, but we're supporting them, and putting folks in places that are harmful is not supporting them, and also going to then be met with burnout and lack of retention. So making sure that we speak the climate is going to be important here. And lastly, working with Black students at the primary and secondary levels. So quite a few folks talk about their interests and how they even got exposed to the maternal health clinicians and the workforce and the options, the professions. And no one spoke about there being support at their high school. And we know that that's where we have these large gaps in the STEM fields and various other gaps, but really working with these younger populations to grow their entrance from the start, really even showing some exposure of what this looks like. If you're interested, maybe doing shadowing. And I will say that there are some great options that can be replicated in other communities. So the Alameda County Health System has a career development program for Oakland high school students, and it includes labor and delivery. So young people can earn elective credits, receive a stipend or college scholarships, and this is really trying to get young people exposed early to make sure that we're increasing representation in these professions. So that is another way that other communities and states can really replicate and really keep this going, make it larger even in California itself, because it is only in Alameda County at the moment. So again, thank you for that. I did want to quickly go over just their findings and our recommendations. Again, I'm going to plug the report one more time. Please read that report. But I am going to turn, we have our invited amazing panelists who are very busy, often on call and working long hours to assist our birthing people at any moment. So I want to thank y'all for making time, but I invite you to turn on your cameras. May we welcome Patricia Labrie Calloway, a labor and delivery nurse at Highland Hospital, and also a nurse manager for Building Bridges for Healthy Baby in Alameda County Public Health Department. Dr. Cooper, who is an obstetrician gynecologist, also at Culture Care in Oakland, California. Samaya Suleiman, a nurse midwife and labor delivery nurse, a scholarship coordinator at Mercy in Action College of Midwifery, and Dr. Cassandra White, who is an OB-GYN at Highland Hospital in Oakland, California as well. Thank y'all for joining.
Thank you.
So I do have a few questions that I have prepared for you all, and then I do have some open questions if we have time before opening up the Q&A for our larger group. And I shared this earlier, but I wanted to make sure that we heard from you all, who better to share your experience and about this field than those who are in the field. So my first question is to you, Dr. White. Can you tell us a little bit more about your mentorship from students from underrepresented or invested communities and the need for this investment compared to traditional supports?
Sure, thank you. And thank you to the Urban Institute and all the researchers for your hard work. I think for many of us, this is a very passionate topic, either through lived experience or we know someone who've gone through. So yes, mentorship, as you mentioned in the presentation, has been a huge focal point for me. Whether it was mentorship in the capacity of a family member or a counselor, a friend, they've all played a key role in my needs in this journey, whether it was letting me know what the steps I needed to take to apply, to get in, to interview, or it was a matter of just keeping me whole and grounded, much like my family. And that's kind of where I work with many of the students who are interested, pre-med students who are interested in going into medicine, is my relationship with them becomes somewhat of a family. It's not just driven towards reviewing a personal statement or going over topics or key points to interviewing, but sometimes tapping in. How is your emotional state? How are you handling the responsibilities of your family? You know, how do you set boundaries? Trying to teaching them how to set boundaries early, which becomes important and becomes the point of self-care. And that in itself is a big part of my time with mentorship. But the other part also is I actually do know that I have access to certain opportunities and experiences. So I make sure that I tap into either individuals that are offering those and let them know, you know what, I have a very motivated pre-med student here who wants to be exposed to maternal health. I think they're going to apply and I want you to really consider it. So it's being in those, knowing that I am able to be in those spaces and be able to provide that opportunity. The other is, and I hope I'm not going too much off tangent, but this is kind of the scope of how I see my mentorship with my mentees, is also creating transparency. I let them know the things that I've experienced or even currently experiencing. So that way they are also prepared, not just for their clinical experience, but preparing mentally for some of the challenges that they may face throughout school residency as an attending. Yeah. Oh, and then the other is sometimes, you know, I think about also, you know, for many of us, and as you mentioned in your presentation, being a first generation, right? Not even knowing where to go, who, what, when, where, how. And that was for me. And so trying to get many of my mentees to a place where they're not repeating some of the mistakes that I made, but also shortening their journey in a way where they can reach their goals, hopefully a little bit faster.
Thank you for that.
Yeah. Thanks for asking. And as you mentioned here in Alameda County, I mean, we have, you know, here at our hospital, we have students that come. I think we're working currently on a dual apprenticeship. And there are things that are really evolving here that hopefully will reach the nation on a grander scale. And they really truly see the benefits of such a collaborative workplace and also nurturing that pipeline of Black clinicians.
Absolutely.
Yeah, for sure.
Thank you for that. And I may come back to touch on some other things that you mentioned. And I wanted to turn to Samaya and get some from you about this. Like, I know the mentorship role for a preceptor is very different, but to hear more about the desire and difficulty maybe for identifying preceptors of color and like what that looks like, everyone on the call today may know.
Yeah, hi, thank you for having me. It's really great to be here, so thank you for inviting me to this. But I think, so I work at Mercy in Action College of Midwifery. That's also where I graduated from school in 2019. And then about a year and a half later, I came back to be a part of faculty and then start the scholarship mentoring program. And basically it was something that I just wanted to create for our students of color to just kind of get together every month and just talk and connect and build community. And this is something that I kind of mimicked from a group that I was a part of in DC when I was a student midwife. And it was literally just like, you know, doulas and labor and delivery nurses and midwives getting together and just kind of sharing our experiences together. So I wanted to bring that to Mercy in Action, especially since like we're just at such a small, intimate school. And even one of our students, like our school's broken up into cohorts, and one Black student, she's the only person of color in her cohort. So I thought something like this would be really, really important. But there's variety and kind of trouble that our students are seeing. Some, you know, implicit bias exists. And it can be really challenging getting preceptorships, especially in places where Black midwives are just like not around or they're not prevalent. You know, I think if I remember correctly, Black midwives, I mean, we make up less than 5% of the population midwives, like a very small amount. So finding those preceptorships for clinicals can be quite a challenge. So we're running into kind of like some even microaggressions. Like I had a student telling me about, you know, just little things like, oh, you know, they weren't putting me to be on call. And it's now taking her more time to finish the program. So she should be ahead, but really she's a year back because there was some things going on that maybe weren't quite fair. So that's putting our students behind. So it's like having to mentor these students through that and helping to find solutions and, you know, like seeking, like knowing what are red flags, which can be hard, especially for somebody who's wanting to be a midwife and do good work. And then running into things like, you know, she was telling me on their page, the other students got, you know, their pictures put up on the page, but hers didn't, things like that. So it can be really, really challenging. So I think with this scholarship mentoring program, I really just want to nurture our students so that we can successfully graduate as many Black midwives and other students of color as possible and, you know, just have good success with that. And so we do offer a scholarship, and for you to be awarded the scholarship, you just have to complete. So the program is a 4-year program. So the first 2 years you complete with a GPA of 3.0, and then you're attending these scholarship meetings. And then we award that tuition scholarship for the last 2 years of the program. And we're doing really well. So, yeah. I hope that answered your question.
Most definitely. Thank you. I appreciate you uplifting that experience and what you're hearing from other students. Oh, I think Dr. Cooper jumped off. I did have a question prepared for her, so I'll field my next question to you. Patricia, may you tell us a little bit more about your pathway into L&D and any typical entry of specialty into the specialty that you've heard from colleagues?
Okay, thank you so much for inviting me to participate. I enjoyed doing the interview. and learning more about the topic because I'm very interested. So my pathway was different. It was many years ago. I've been a nurse for almost 40 years. And at that time, I just happened to be a registry nurse in the hospital, and I worked wherever they sent me, ICU, med-surg. And I heard about a program for intensive care nursery. And I just went up to the head nurse and said, I'm interested. And she put me on the list, and they picked 8 of us. So that's how I got entered into intensive care nursery. Well, while I was working there, I kept going down to labor and delivery down the hall because I was intrigued, and they were always so busy, and I was wondering what the board was. And so the mentorship from the nurse midwives and the other nursing staff was like, here, come help us do this, come help us do that. So it wasn't a formal learning, but it was right there on the floor working. There was an African-American head nurse who said, hey, you want to learn L&D? Come down here where we'll train you. So that part was an entryway, which, you know, other people, other nurses, African-American and other nurses who get into the maternal child health come through. Of course, you have to have your nursing degree. And then you may have a BS or ADN or a master's prepared nursing. And then they may want you to work med-surg initially because they feel like, you know, you would have a good experience, a good backbone on basic nursing care. And usually it is informal. You may be invited because you go and ask the head nurse, or it's through word of mouth. There are some hospitals who do have specific training programs for nurses, very, very competitive, particularly with labor and delivery nurses. And usually if you don't have the bandwidth to train them, like you may not have a nurse educator at your institution, you can only take a few nurses at a time. They would be offered mainly the night shift, so that could be a deterrent to others. But when I think about the journey too, I also want to include public health nursing. So for maternal child health, there are nurses who work in the field, in the community, at the home, touching clients after they deliver their babies or before they deliver. And they're also part of the perinatal maternal child health team. And they can influence, they can assess, they can find out issues at home that you may not have discovered in the hospital. So it's the continuity of care that clients can receive. And if you have nurses, a diverse group of nurses who reflect the population that we serve here, you know, you'll probably get a better job satisfaction. There's the communication with the clients, the trust that you may have built already in just them seeing your face. And then the opportunity to learn more about other cultures also, and to spread your knowledge, kind of decrease the implicit bias that clients may see. So we definitely want to have that opportunity for clients to have a good experience during their maternal child process, but for the nurses to be satisfied also. But I think in your report, you said, hey, we need more programs to have some special L&D trainings, increase that. So if we want more diversity in maternal health, we have to be able to have those type of programs and invite others to join. So.
Oh, thank you for that. And also thank you for bringing up that culturally effective care. It came up where that isn't always a part of training. So, and our other interviewees shared that, you know, they have to be the ones that bring that up. So having those opportunities to build that on the job is important as well. And oh, thank you, Dr. Cooper. I was going to field you a question, but you hopped on. Sorry about that. But may you share about your motivation to start your own practice and the model that really sets culture care apart?
Thank you. Thank you for having me. Sorry, I had some technical difficulties. You know, the internets. So I'm co-founder of Culture Care, and Culture Care really came from, and probably moving out to California. I'm not a native. I moved here for my first job after residency. And it was the best of times. It was the worst of times. I felt this connection with my patients where people were coming from all over, like from Sacramento down to Oakland, because there's a Black woman who was at this hospital system, which I will not mention, who was available. And people were, I was like, wow, like, you know, you get this much, you know, of a following, and this is not social media following. I'm like, people who are actually coming out their homes to come see you. And it felt good because I was like, okay, this is what I want to do. The hard part became, how do you get treated in a system where, you know, you're your Black girl magic is attracting different people to come get care from you, but you're also being, you're not having the best experience in terms of being a coworker. You're not, from the HR standpoint, it's not good. And so that was a very short-lived situation because, and this is, I think when we think about, all of this diversity inclusion stuff, if you don't do it at the staff level, if you don't have a diverse workforce, then, you really don't even know the problems. And I can tell you that how us as clinicians experience our coworkers, we're not surprised by the statistics, because if they can do it to us who are actually enabled and have some powers, patients are really vulnerable in this respect. So I honestly started Culture Care out of a desire to give Black women access to Black doctors. We know that Black doctors, thank God there's lots of evidence coming out that's saying that when we are just in the population, the life expectancy goes up. That's a new paper that just came out. When we are in the community, patients get their testing done. They get their preventative care done when we're their primary care physicians. When we're the pediatrician, then neonates survive. And so really, Culture Care is really about giving access to Black doctors and outside of the traditional healthcare system, which is predicated on insurance, because a different term is, especially in California, who you can see. And so while I know like a host of Black, OBGYNs as girlfriends, they can't see, when people ask me, oh, I want an OBGYN, I have to ask, what's your insurance? Because that really is what divides a lot of access. So we actually are outside of the insurance system. We only take a copay so that it's affordable and accessible, because once you put insurance on it, then it kind of limits who can see who. And so the virtual aspect of what we do, which is completely telemedicine, is so that no matter where you are in the state, you can access our services. And that's really, I really wanted to, create the role that I wanted to be in, the type of OBGYN I wanted to be in, where I felt supported by my colleagues and felt I was on a mission, but also could support patients.
Thank you. You're, I promise, hitting the nail on the head, especially related to some of the things that are coming out of the report. I wanted to turn back to you, Dr. White, more about the diversity and the leadership as we're on that topic. May you speak more about your previous role as Chief of Obstetrics and Medical Director of the Family Birthing Center, and like that role, that importance of having diversity and leadership?
Yeah, thank you. And Dr. Cooper is my colleague. I'm just saying, proud of her. I'm proud of you all, but proud of her. It's my decision for stepping into such a role was recognizing how I could influence decision-making processes that ultimately trickle down to how we care for patients. And I've always believed, and still very much see, that everything we do from the very beginning to the end, from the top to the bottom, from the bottom to the top, all has influence on how patients are receiving quality care, but also how, if they will return, which goes into what Patricia mentioned, trust. Are we building trust? And what bothers me most is, yes, we are losing our Black clinicians in these spaces, but we also are not building that trust where patients don't want to come to the hospital when they may actually need it, where there may be emergency services or high-risk situations where our birthing people actually do need to be in the hospital. Now, once they get to the hospital, then now what happens? And that will then determine whether their outcome versus, as well as whether or not they will return for postpartum care or their continued care within our system. So that was a big personal reason for even stepping into a role as OB Chief and Director of our birthing center. Much of what I envisioned as that role, and still how I practice to this day, is a modeling practice, right? Like I go into work with the full priority that the patients are my priority. That even means stepping away from anything personally that's going in my life. Everything is separated. It is completely to the patient. There were other things about setting expectations with other leadership members, colleagues, are setting expectations as a full department, and then also being a support system. But it's really about setting the tone and the culture about why we are here and what purpose that we're serving. I still think, even though many of our patients prefer to probably deliver outside of the hospital, we still get over 90% of births that still occur in the hospital here in California. So it's still extremely important that we're doing right by our patients. And something that I really stand as far as like, if we're going to change, is how we're holding ourselves as well as others accountable, and our view on accountability, and what are we not willing to tolerate, right? And so I think about leadership. If I'm thinking of leadership as a whole, there are just certain key qualities, and there are many, but there are certain key qualities that I think really need to be amplified if we're talking about diversity. And if that looks like either one of us or just someone who understands how important it is to build trust, to provide growth opportunities equally amongst team members, and really looking at it away from innovation and being transformative, and understanding how valuable it is to have a diverse organization as a hospital, residency program, medical school, those that are in decision-making spaces. That in itself then fosters growth and opportunity and health as well, right? Like, I mean, everything just completely improves from there. And then within that bubble, leadership is management. And those two things they have to communicate, right? There has to be this really tight relationship between leadership and management. And it's within that bubble that really is there. And within that, management is really ensuring and checking and making sure that policies and procedures are inclusive, and that they are not created in ways that could place harm on our patients, right? Could introduce the biases. And I could go on and on and on, but there are management practices that can limit the scope of anti-discrimination. And then we start getting into other things as well. And I think that's where it becomes truly important that we have a diverse leadership who's willing to be transformative and understand the purpose of their decisions.
Thank you for that. And I'm not sure if you see this coming, Patricia, but turning to you to really speak about your previous and current roles, quality coordinator role and nurse manager, and a little bit about what you bring to that role and the importance of diversity, if that makes sense for patient and employee satisfaction.
Okay, thank you. So I'll give an example for the quality coordinator role. So I worked in HIV for about 10 years, and I was new to public health. And so my role was to work with all of the different programs who provided primary care, mental health services, case management, et cetera, for clients, home health. And part of our role as program managers were to develop and present an RFP to the community and be able to select different programs. Well, we had an African-American leader at that time, and he selected me to do the RFP ones. And I had never done anything like that, but he gave me the opportunity. He mentored me throughout the process and made sure I had everyone around me had to respect that I was the one leading it. And he put me in a role that I was outside of my comfort zone. But because he was there for me and provided people there, it made a huge difference. So eventually with that role, I was trained by HRSA and ended up doing trainings for classes for quality improvement in several parts throughout the country for those African-American staff who were mainly the staff working in HIV at that time, and learning how to do quality improvement, looking at health outcomes, how to document, how to collect the data, how to run meetings, et cetera. So in the role now, I'm moving specialty to now, I'm a nurse manager, and this is in public health. So we're a home visiting program. And it's so important to have that diversity because of communication with our clients, like I talked a little bit about before, but working with staff to get opportunities, like I was afforded opportunities to learn and do other special projects throughout my career in public health. So I really try to work with the nurses to say, let's move out of your comfort zone on its own. You can help write this policy and procedure. You can give your input. Let's mentor students, particularly students of color, who may be a little shy about coming into the place, telling our stories to others, and saying what might we have done differently, or what did we learn from that. So I think it's so important to have diversity in the workplace. It can give us some opportunities. We can help set standards. When you think about nursing, there's like 3 million nurses in the United States, only 10% are African American. So that number, and think about those who want to enter in maternal child. Like you said, how do we make opportunities? You can't start taking chemistry in college and probably do really well. We need to start and really get involved in our communities at the level of even preschool, grammar school, and let them know, what is a nurse? What kind of career is it? How do you get into it? What type of training you need, and all of the education that you would need to move forward. So I think as a nurse manager, it gives me opportunities to be in a decision-making process, and also to mentor the staff and push them a little bit out of their comfort zone, which we've done several times. And then people go, oh, I could do this. I can do a presentation. I can lead a community forum. So those kinds of things are the groundwork that I do. But thank you. I answered it.
Absolutely. No, thank you for that. And even illustrating in your previous role that mentorship, like we see that this mentorship is important even for advocating for you when you're not in the room. So being able to make sure you get opportunities, as Dr. White has shared, like I know this is an opportunity, I'm speaking to the person and making sure we have young people in the right rooms and the right spaces is very important. And we kept hearing that over and over again in our interviews. Now we are coming close to time. So I wanted to take a quick look at our Q&As from, all right, and we'll come, okay, so we should have a little bit of time. I'm gonna fill one last question. And this is for you all to jump in as you see fit. So we spoke a good deal about race concordance, but censoring hasn't been named yet. Would any of you like to speak to censoring? Or if not, we also have another question about any specific difficulties or unique opportunities that are specific to California. So those are the two last questions I just wanted to put out for you both to, for you all to jump in on.
Mm-hmm. I think I'll just be brief about doula care. So as a L&D nurse, we do work with doulas very closely. And I love working with doulas because to me, they're part of our team. And I know recently in the health department, there will be doulas that are trained. There'll be some reimbursement through Medi-Cal. And it's just getting entry into hospitals, can be a barrier sometimes. But I think when you have a well-trained group of doulas and they're welcomed as part of the healthcare team, and they can build trust. They are a diverse group that match the population we serve, and opportunities to train people who have been through the birthing process to become doulas is very important. And we do really embrace that. In fact, one of the programs is Embrace Her. We work closely with Dr. White at the hospital there. So I just want to put a plug in for doulas. I did see that mentioned in the chat.
I think there's a question about, I think you asked about something else specifically for California statistics.
Oh yeah, feel free. Yes, if you would like to speak to that.
Well, I mean, I think some of the earlier work of the CMQCC, which is what basically is the maternal quality arm of California, has noted that, we say 3 to 4 times usually for Black women being more likely to have maternal mortality in the whole country, but actually in California it's 3 to 6 times more likely for Black women. And a recent study just came out, it was actually an economic study looking at how much your socioeconomic class or your salary impacts your ability to die after childbirth or peripartum. And actually, it was not linked. It was linked, obviously, to socioeconomic class, but race, no matter how much money you made, you still were more likely than a white woman who was low class in terms of her salary to die. And so that again is just, I think so many times we get wrapped up in socioeconomic class and you have to go to certain neighborhoods and do impact. And, definitely what was done at Alameda Health System is important, but it's not the whole story. It does not matter how much money. There's no way you could out-earn yourself an ability to prevent you from being, to falling from this. And so that is where we have to talk about this with the lens of race and make sure we center the race conversation, especially because California has the best maternal mortality rate in the country, which is not saying a lot because this is the US, but the fact that Black women still are more likely to die here is still showing us that there's a racism situation that we have to deal with. And of course, like you talked about from your project, from the Urban Institute about, the diverse workforce, all those different things are a part of it. But, again, like, doula is like, who is the workforce and who is the community and who, and one thing that we haven't talked about, we talked a lot about clinicians, but also social workers, like, I feel like social workers have always been important to the work that I do. They do the stuff that I really can't handle. Like when I was in residency, they got one of my patients, like their lights turned back on. Like those are the things that make sure that people are well, that don't happen in the hospital per se. And so really, I think we can talk as much as we want about, what we think it is, but really let's just talk about it. It is a Black issue and it is a racism issue, and I think that's just the thing that I want to center in terms of California. Like we are not immune from racism. I know this seems like a very like flowery, chill place and it's all good, but it's really all racism as well.
Thank you for situating that context and those rates in California. And I did want to see, we do have some questions in the chat. I'm not sure. Yes, one is about some of the recent studies on representation and health outcomes. Some of those are in the report, so you can find those links. And then to the doula support, I do want to do another plug for CHCF, the California Healthcare Foundation. Under this work, we were not focusing on doulas, but that is work that is included in their birth equity portfolio. So like keep your eyes out for that. And they are definitely important in this conversation, but again, with some of the confounds that we had and wanted to make sure that we pay special attention to some of those differences in like licensure and training, they weren't included, but not to say that we think that they are any less of important in this space. And we only seen 2 come through. Are there any other questions from our attendees? And if not, I can open it up to our panelists. Were there any other items you all wanted to speak to that we didn't get a chance?
I did. Sorry, Joe.
Full straws.
Yeah, I think because you're in DC, is that right? Okay. We do have a bill that passed called the SB 331 that passed in January of 2022. I'm not sure if you're familiar with that, but I think it's a really important bill that looks at how accountability factors are applied to employers. Since we are on a platform talking about retaining Black clinicians, right? This particular bill is important because it basically means you cannot be silenced if you are discriminated against. And on the grounds of discrimination, sex, gender, race, either discrimination, harassment, toxic workplace environment, and that it becomes unlawful for you to be silenced. And so when we start seeing we start hearing more stories about experiences and where organizations can really at the ground roots deal with racism and discrimination within their own systems, patients, clinicians who are Black, that they really can avoid getting to this point of a legal or judiciary system around racism in healthcare, but they recognize that there also have been limitations to anti-discrimination. So that's why I brought up this particular bill, because it creates transparency as a whole. So anyway.
Thank you for that, especially
Dr.
pointing
Cooper.
to California. Dr. Cooper, before we hop off.
I was really gonna let her leave it there, but I just wanted to pub, since you are in DC, that I think one of the foundations for me being who I am is definitely that I did go to Howard University College of Medicine. And I think the normalcy that I had in medical school, that doctors just are Black and nurses are Black and the whole team is Black. I think it was kind of like an oasis that once I went to training, when that wasn't the case, I definitely felt like, a lot of the gripes that were mentioned in your project. And I think a part of the future also is hopefully to get like midwifery schools and HBCUs. I did not meet a Black midwife until I moved out here. And so I think, really, I think HBCUs have always been the answer in terms of healthcare. Most Black doctors have gone to HBCUs in some capacity. And I think we really just have to, again, put respect on the name, because that is really the way forward, is to remember where we came from. So thank you.
No, thank you for that. And I think that's a great way to close us out, honestly. I want to thank the panelists and the attendees again for your time. Please engage with us further on this topic. And another plug, when you leave us, please take a moment to tell us how you're doing in this brief survey. You can see the link on the side, and this recording will be sent to all attendees, or you're able to access it later. So that's all the time we have, and we want to be respectful of that. So 2 minutes back in your pocket.
Thank you.
Thanks, everybody.